The terminal expectant treatment. The terminal and expectant treatments of acute urethral gonorrhea are not precisely the same thing. The expectant treatment consists in employing no local repressive measures, letting the disease run for 3 to 4 weeks until it begins to abate, and then applying local measures. Terminal treatment includes all measures applied during the stage of decline, whether the case has been through an expectant or a repressive course. Terminal treatment, therefore, begins in the 3rd to the 5th week of the disease in 2 classes of cases, viz. Those that have been controlled but not cured by repressive measures, and those that have begun to abate spontaneously. Precisely when to begin terminal treatment in either event must depend upon the judgment of the physician, founded on his previous experience. If the case has been treated expectantly, terminal treatment is begun according to the method used for repressive treatment. By this, the symptoms are very promptly controlled, and within a week or so, the case is usually ready for actual terminal measures. Terminal treatment begins with examination of the prostate and vesicles, even if the second flow of urine is and always has been clear. The patient urinates to clear the anterior urethra of pus, but retaining a little urine in the bladder. The prostate and vesicles are then gently massaged, a small catheter gently introduced, and the first urine passing through this caught and examined for pus. If this is found by microscope, the case is treated as one of prostatitis or vesiculitis, page 235. If not, as one of urethritis. In any case, this examination is concluded by a bladder irrigation with 1 to 8,000 potassium permanganate. Thereafter, the patient continues to use anterior injections himself and returns to the physician for treatment of the posterior urethra. Treatment of the anterior urethra. The patient uses an injection twice, rarely thrice a day. If the discharge contains gonococci, this injection should be antiseptic, usually Protogol 0.5%, if not, astringent, zinc salt. Such is the general rule, yet it is always well to experiment with astringents, even in gonococcic cases. Order 1 astringent injection a day in addition to 2 antiseptic ones. If this diminishes the discharge or clears the urine, the astringent may replace the antiseptic still further. Indeed, it is not uncommon for gonococcic cases to do better under an exclusively astringent local treatment. Non-gonococcic cases, on the other hand, may do well for the first week or 2 under argyrol or Protogol. Treatment of the posterior urethra. If the case is progressing satisfactorily to a cure under anterior injections, no treatment of the posterior urethra is required. But if there is a halt in this progress, as judged by the 2-glass urinary test, or if prostatic massage reveals prostatitis, or if the second flow of urine is slightly purulent, treatment of the posterior urethra should be begun by posterior irrigations once a day or once every alternate day, combined with the treatment of prostatitis, if this is present. The frequency and the nature of the irrigation varies according to the idiosyncrasies of each case. Permanganate in weak 1 to 6,000 or 1 to 8,000 solution is the most generally efficacious. Silver nitrate and silver permanganate stands second. If irrigations irritate, instillations must be employed. If this treatment fails to cure in a few weeks, the case must be considered chronic and treated accordingly.